Hi, everyone, and welcome. We are so glad that you were able to join us here this afternoon. My name is Gracie Vaden, and I'm the membership manager here at Volta. I'll take a moment to introduce who we are before we dive in. Volta is a student health platform that helps universities streamline immunization compliance, reduce administrative burden, and improve support for their students. We work with schools across the country to make health requirements easier for staff and for their students. This series, The Current, is really about elevating the voices of campus health leaders, and we're so excited to kick things off with Dr. Jim Jacobs from Stanford. With that, I'll turn it over to Chakata to get us started.
Awesome. Thanks, Gracie. Hi, everybody. My name is Chakata Pena. I'm the founder and CEO here at Volta Health. Before Volta, I served as a Fulbright Fellow in the Republic of China and a captain in the U.S. Army Medical Corps, eventually earning a medical doctorate from Brown and an MBA from Yale, where I first started this business. And Gracie obviously just gave a great overview of kind of what we do, but I really do want to emphasize this session and all of those that are to follow are not about Volta actually whatsoever. I think one of the things that I have to note is that there's no such thing as a very useful Wikipedia page for college health, right? So, our team at Volta really wanted to change that by creating a series that meaningfully contributes to this field by learning directly from those voices that have shaped and are shaping the future of college health and in turn the future of the next generation of young leaders, thinkers, and creators. And since Volta, takes its name from a river in West Africa, we felt it fitting to call this series The Current. And as we sat back and try to think through who should lead our first conversation, all roads pointed to Dr. Jim Jacobs. If you work in college health, you've likely heard of him. He's talented and he's the approachable executive director of the Vaden Health Services and AVP for Student Affairs at Stanford. But his career spans some of the most respected institutions in this country, from Syracuse to the Ohio State University, where Gracie's an alum, to USC and even the Department of Homeland Security. But his professional journey began by him earning an MD from Duke and a PhD in biomedical engineering from UAB down in Birmingham. But to me, what's most telling is that he truly embodies what the American dream should be, right? He was born in Wyoming to a blue collar family and moved from small town to small town as his father worked in construction. And so let's begin there, Jim. You've had a unique journey. So looking back, how would you say your early experiences really, moving around the country really shaped your adaptable ability as a leader in so many different institutions?
Thank you, Dr. Pino, and thank you to Volta for sponsoring this series. And it's an absolute privilege to be the first speaker. So thank you all very much, and thank you for the gracious introduction. So that's actually a really interesting question, and actually ties directly into some of what you actually just mentioned. Because we did move around a lot as a kid, I have never been hesitant to move in my career. And I remember at one of my positions, like the first or second week I was there, was the time of the year where you do recognition for staff longevity and contributions. I remember handing out the 10-year pin and the 15-year pin and the 20-year pin, and thinking to myself, I am never going to be able to get one of these because I've had multiple experiences. I'm almost 10 years at Stanford now, which is the longest I've ever been anywhere. Uh, but I do, I thank my parents and the zero regrets about the fact that we moved around a lot as a kid, and it absolutely had an effect on my adult life.
Yeah. Where was your favorite place? Kind of growing. I grew up also, I tell people my friends joke that you can say that you're from wherever, and I'll say, oh yeah, I'm also from there, right? Because I just moved so much. So, like, where was your favorite place? What really, made Jim who Jim is today?
Mm. So I have to say Greeley, Colorado. because in spite of all the moving we had done prior to that, I was able to go through all of junior high school and all of high school in one place in Greeley, Colorado. And uh, I I used to call that home. My family doesn't live in Colorado anymore. They continued to move around after I left for college. But Greeley was a great place to grow up. Um, uh, those familiar with Northern Colorado at this point know everything Denver, Greeley, Fort Collins, Loveland. It's just now a a huge suburb of Colorado. But Greeley was a fantastic place to grow up. But I also say that I've enjoyed living every place that I've lived. And um, if I had to leave what I'm currently doing, my I would probably go back to Columbus, Ohio. Um,
Wow.
just
Gracie's
it
going to be
was
very happy to hear that.
it's a Columbus is a very easy and good place to live
Yeah.
as an adult.
One of our first, I guess, pilot, partners was Ohio State, and I went from having never been to Columbus to going there, I think 6 times in 1 year. And I, I genuinely did think about moving our company there because I was like, These are the nicest people I've ever met in my life, and like, what do you want from me, right? Like, why are you being so nice?" But um, I think yeah, no, nothing but great things to say about, obviously, Ohio State. But, throughout your career, obviously so much has changed, right? I think one of the things that I really want to get to later on is just like this ongoing budget crisis that everybody's facing. But what do you think is, from your perspective, what's most different from working in campus now, health now versus 10 years or even 15 years ago?
I think trying to answer that would be easier if, for example, if I had been at one place for over that entire time frame, because I'm sure you've heard this multiple times, and it's sort of the ongoing um, uh, truism of college health is if you know one college health center, you've known one college health center, and uh, I really think that plays into the answer to your question because it's hard to think about how things might have changed at Syracuse when I was there in the early 2000s versus how things play out here at Stanford because of the just the institutional differences. Um, but I think that I mean two answers that I would give uh, are the maturation of how we think about college mental health. Um, I'd say in the early 2000s, and I personally equate a lot of things back to the tragedies at Virginia Tech, um, and how that really, in my opinion, changed the landscape of student mental health to where anything that went bump needed to go to the counseling center, and
Mm.
and that resulted in what we later called the college mental health crisis, in that we simply did not have capacity in our student health services uh, to uh, work with every single student who was having an emotional moment or and those situations then decreased our capability to do the crisis work that we're probably um, more appropriately here for. But I think that's matured a lot on most of our campuses over the past um, 15 or 20 years.
Yes.
And the second second way I would answer the question is we do talk about money a lot more than we used to. Uh, in the simplistic way, there was a health fee. The health fee generated a certain amount of money, and you kind of lived within that bucket. And again, every campus is different, up to and including 100% fee for service approach to student health. Uh, but I think that the conversation about funding of student mental health, sorry, student health services has also evolved and matured over the past 20 years.
Yeah, no, it's a great thing. I'm not great at keeping secrets, but there's something that our team is working on that we're really hoping addresses that. But this to that point, one of the questions that somebody we both know very well, Richard Keeling, wanted to ask, and it's not a tough one, but he and I had a conversation on Friday that I thought was really fascinating, in which a lot of institutions try to model their health center in a way that is like a primary care setting, right? There's others, I think now more so, that are more urgent care centers, like the Vaden Health Center. I think you all are very explicit in that this is an urgent care center, right? But I went to Yale, and Yale Health Services, you have a primary care provider, and this or this. What are your thoughts to kind of those two models per se of running an institution?
So when I hinted before we logged on that there was topics that I hoped we had got to,
There
this
you
is one of
go.
them.
You
So
can thank
thank
Rich.
you,
I had
thank you, Rich.
no point.
So and just maybe a slight not correction, but we hold ourselves out as ambulatory care and primary care
Sure.
in my own center. We very specifically say we are not urgent care because at least in California and with regard to accreditation, that implies an entire different
Got it.
set of rules. So our student health services is really, ambulatory and primary. Um, and I would say that most students want ambulatory care rather than primary care because they want to be seen when they want to be seen, and they don't necessarily care who they get seen by. They just want to be seen when they want to be seen. So I'll call that ambulatory care without the acuity level of maybe of urgent care. So I think this is a very important topic of what is college health? What should we be? What can we be? How can we afford to be what we think we want to be? And a very difficult question of who gets to decide. Um, and so this again is very regional. I mean, I live in Northern California, where as a older professional with really good health insurance, it takes 3 to 6 months to get an appointment in primary care. Even with an established primary care relationship. That's an eternity for our students. And so my question would be, why would I want to model our student health services after that primary care model that exists in the region where I live? That's certainly not globally true, but there is pressure, and when I mentioned a few minutes ago, the increasing scrutiny of the financial aspect of student health services, and why don't we just take insurance? Why don't we act like the primary care clinic down the street? If they can afford to be in business and see patients all day, every day, why can't we do that? And I think that a question probably for everybody on this webinar today is, what is college health? What is it supposed to be? And how do we, and I don't want to use negative references, but this may evolve more as we go through this conversation this afternoon. How do we justify our existence when there is that private practice down the street? And so whether we call it urgent care or primary care or ambulatory care or something that doesn't exist out in the real world, what is our primary mission from my perspective is access. We have to provide access to our students, and it needs to be better access than the 3 to 6 months that I just mentioned that I personally can get. And so how do we need to be different in the way that we do our college health practices so that we can be available to students in a way that's, and again, the idea that I need to be seen this afternoon for my sore throat, we've all been there, done that. Got the call from the parent about that situation. So I'm not saying we have to be instantly available, but we can't be 3 to 6 months the way that a lot of private practices are around the country. So I think, what are the values of your student health service? And I would espouse that for me, the primary value is access to all the services we provide, whether that be on the mental health side, on the primary care side, on the well-being side of the equation. How do we provide access and I'll look forward to seeing where maybe how other questions go that touch upon this, but that's a combination of funding, staffing, philosophy, scope of services that are offered. And if you're not 100% busy 100% of the time, you probably need to figure out why. And that does not bode well, in my opinion. If we need to be 100% busy 100% of the time. I don't want to be 110% busy, but I want us to be 100% busy. Maybe not during the dog days of summer, maybe not during the last couple of weeks of December, but the rest of the time we need to be busy.
Yeah. No, it's that answer touched on a lot of questions I think I wanted to get to, but I think the first and foremost on everybody's mind is money, right? Money, money, money. It's a very difficult time in higher education right now, and budget constraints are just, leading to just things that we didn't think were really possible, right? So how are you navigating the rising costs, especially when resources aren't keeping pace, right? I guess at Stanford, which is some would probably think or say it's a well-resourced institution versus, other places that might not have the resources that a Stanford might have.
So we could obviously talk for hours and hours on this question. I'll raise a couple of points. Yes, I'm well resourced where I am, and yet we have wants and needs. I have so much admiration and respect for probably the majority of schools around the country that are not well resourced and are really having to stretch things to meet the needs of their students. So, the health fee, I don't know the percentage, but a lot of schools, most schools, do have a health fee of some sort. And I would venture to say that at a lot of schools, that health fee bucket is subvened by the university to create a little bit bigger bucket in order to accomplish what the student health services needs to do. Some schools are 100% constrained within the health fee and can't do more. So if they choose not to raise the health fee this year for political reasons, or the 3.5% increase in the health fee, that does not keep up with medical inflation. And so, how do we hire? I mean, when the private practice down the street is not necessarily constrained by those same numbers, how do we hire? How do we retain? How do we pivot to offer new services that are in keeping with new developments in medicine? And I think this will be the question for the next 10 years of college health, up to and including the possibility that on some of our campuses, it's not going to be possible to do college health anymore. And indeed, the university is going to say, well, there's a private practice down the street. Take your insurance and go to that private practice, but we're not going to provide the service on campus. That's an extreme view. And I think that's much more likely for primary care than it is for mental health services. And we could talk about that later or not. But I think it's almost an obvious point that most of our campuses don't have appreciation for what we do in primary care, and they're terrified of what we do or don't do in the mental health space. And again, I think that's probably a truism that works for most of our campuses. So, how do we survive in the current budget situation? I think so I just laid off a number of staff as part of Stanford's response to the federal landscape that has affected so many of our colleagues around the country. Actually, less so to date here at Stanford, but nevertheless, the university went through a budget reduction process this summer. I've never had to lay off staff ever in my career, and so and the health fee isn't going down because we reduce staff. And so how do we explain things to students if they no longer have access to a particular service that we had been offering? And I think transparency and honesty with our students is very important, because if we can't afford it, we can't do it. It's on some level, and so we have to be honest with ourselves and with our student populations to say, look, we had to reduce in this area, and so that service is no longer available. Here's some alternatives, and we hope that our students are well enough insured that they could use insurance if they had to, for to seek services that we had previously provided at no out-of-pocket cost, as under the health fee or whatever funding model exists. So I think we're going to have to be clever, and we're going to need to be transparent with our populations to continue providing as much service as we can, but also being honest about the realities of where we are as a nation, as a campus, as a health service.
Yeah, no, I mean, I think it's a great question. That's something that our teams, certainly looked into a lot in terms of the different funding models and how, I think it's a real shame that health centers will have to close, right? Because they do serve a purpose for the institution, whether it's from a retention perspective or whatever it may be. But in terms of kind of what we have now, right? Let's talk about the navigating the scope. Or do you want to chime in?
I do. Thank you for seeing my attempt to raise my hand. So I think there's an imperative, and probably was true 5 years ago. It's absolutely true right now. How do we prove our value to our university? Now,
Isn't that by data, would you say, or is there just not enough data, or is there why haven't health centers across the country been able to prove that value?
How do you prove the value of the private practice down the street? It's, people get their salaries. There may be a margin, so they get their bonuses. Maybe they're owned by a private equity group, and those, there's some sort of margin for the owners. But how do we prove value? The way we usually try to prove value is we saw 100 patients yesterday. Yay for us.
Yeah.
That's our value proposition, is numbers in the form of productivity, of throughput. And beyond that, I think we're very unsophisticated at trying to prove our value. Now, again, there's huge differences. There are schools where you can prove value to retention. A lot of schools, I don't have a retention problem. I got 10,000 people standing in line for every one spot that Stanford's willing to offer. So I can't use retention as a marker. And so I'm feeling a sort of a internal conflict to try to figure out, how do we help our university to understand our value? And to me, that comes back to access, because again, if students weren't able to access services and they were being forced to go elsewhere, there's all kinds of other implications that come from that. But I think we have to be able we need to work on proving our value. If we're in a really sophisticated fee-for-service operation, we actually might be generating a margin back to the university, and that helps prove value. I think that's very rare, and if there is any student health service in the country that's doing that, I think that you should put them on your list for this series. I think even in places where there is ultimately a fee-for-service financial arrangement, I think the university is still having to subvene, whether with a health fee or with other subvention dollars, because our productivity models in college health aren't meant to be money making. And when we need to shut down for an hour for a student affairs, all staff meeting, or all the other sort of things that we do being part of the university community, and I'm not diminishing the value of those, I'm just saying they hurt the financial value proposition. And so how do we prove our worth Um, and how do we celebrate that? And how do we, you know, how do, there's very few things in life where I'm going to be happy having to go to the doctor. Maybe I can think of a few things, but like there is no no happy reason for going in to see a neurosurgeon. There's just simply not. But even on our student health service, how do we help students to appreciate what we've done for them? And again, access I think is a huge part of that. But if we're costing the university money and we can't prove our value, that's a really dangerous equation. And so I just would challenge all of us, myself included, but everyone on this call to be thinking of how do we demonstrate our value in a way that's compelling for decision makers of the university. And again, I'm assuming we're practicing great medicine, that we're providing great access, that we're friendly and joyful in the way that we engage with our students. And even then, if the math isn't good, I think we're vulnerable.
Yeah, if the math isn't mathing, as the use my generation now says, that's interesting. I think I I'm really fortunate just to be able to have conversations with a lot of people in the industry. One of the people I've really enjoyed speaking with, and I'm really excited to speak with more is Shannon Kuykendall from UGA. And I think what's really interesting about her background is she came from what I call normal adult healthcare, right? And then came into student health. So, at UGA, they're kind of implementing things that are really kind of commonplace within the normal, adult healthcare world, right? I think it was actually interesting. It was this past Christmas, I was watching the Netflix football games, and something just came across my mind, and I was like, wait, I've never gotten a bill when I went to the health center. And I was in school for quite a while, right, at a lot of different places. And so, do you think that if the industry moves towards that direction of acknowledging that, hey, the way that things have been, done in the past, we just can't really do that, right? We need to adopt more, more innovative approaches, and really, reevaluate things. In addition to, I think, I don't think, health services or health and wellness on campus has a PR problem, but I think institutions or these departments can probably do a better job of doing PR in terms of going out there and saying this is what we do, rather than, just kind of go about their business every day and not necessarily like highlight what they're doing.
Yes, and that private practice down the street that I keep referring to, they don't show up on the front page of the newspaper on a regular basis. Even if patients are unhappy, if families are unhappy, it doesn't create a community uproar usually. Whereas there is a tremendous vulnerability for almost anything that a university does. And, you know, one of my values is to not be known by the provost. Now, I'm very grateful to be known by the provost, but if the provost knows, if we're somehow making it to the provost office, something bad
It's
is
not good
happening.
news. No, I
Right.
tell my team all the time, I'm like, if for the, folks that work on our team, if I have not heard your name, you're doing a phenomenal job. If I've heard your name, that bodes very poorly for what's about to happen.
Right. And that's a dynamic that we experience in college health services, that using your normal adult clinical practice that you referred to a few minutes ago, just doesn't have to deal with.
Mm.
And um, And so, what I'm trying to tie that into is your assertion that, can we find ways to advertise or market or promote the good work that we do? Yes, we can. And there's going to be a student, maybe 10 students, who had the exact opposite experience. And I'm not denying that that it didn't happen. It also happened in the private practice down the street, where the experience just wasn't that great. And so now we are promoting that we're doing this good work, and those students are saying, no, I had a completely different experience. I'm going to write an op-ed for the student paper about, how contrary my own personal experience was compared to what they're promoting. I don't want to overstate that, because it's never going to be 100%, but we're in a very strange space in student health, and we need to embrace that and make it work.
Yeah. Yeah. Kind of transitioning a little bit, would love to talk about navigating the scope of, the service and the limits, right, of these health centers. And want to give kudos to Mike Conway and Jess McDonald here, who I know, Jim, you know them very well, but they put this forth, these questions forth. And one of them I thought was really interesting was, how much autonomy do you have in your role, right? That's a very dangerous question to approach. So I'll give you something else for you to be able to sidestep that. So in which, how do you work within your administrative structure to get things approved, get things pushed forward, to kind of keep going?
So this is a great question, and I appreciate it. And I actually spoke about this at ACHA, gave a presentation about scope of services, and I'm going to do another version of that at the Pacific Coast College Health Association in October. But I think it's a fantastic question. What is our scope of service? What should it be? And who gets to decide? And I will say that my own personal experience has been in 25 or so years of having leadership roles in college health. An administrator has never once told me what the scope of services should be. There have been a few conversations about you need to do more, but not you need to be injecting biologics or not injecting biologics. That autonomy has been 100% within the student health services in my experiences. So, how do we decide what we do? And because primary care can be defined as this or this or this, and it's still primary care. And all of our campuses have different versions of what we're able to offer. Allergy shots is a very volatile example of that. Lots of schools give allergy injections, and lots of schools don't. And who gets to decide? And if you aren't able to provide them in-house, what options are available for students? Because whether you have 500 students or 50,000 students on your campus, there are students that are going to need allergy shots, and there are students who are going to need to be on biologics, and students who need colposcopies, and students who need skin biopsies, and all the various things that we could put within or out of a scope of primary care, ambulatory care. And how do we decide? And I think that, listening to patients, if the rhetoric around allergy shots reaches a certain level, you have to respond to it in some way. And it may be to say that we cannot safely do that in our clinic for the following reasons, but here's 2 clinics within the mile radius that are able to do it. I think it's really important. If we're not going to do it, we need to provide options, reasonable options. Having to go 20 miles into the next big city, that's not a very good option. But there's also some things that we're not going to be able to do. No one expects us to do heart transplants in student health, and I'm being purposefully stupid in doing that. But there's a lot of things that we also don't do that families and patients could very reasonably expect us to do within college health. And so I think that needs to be a recurring conversation within our leadership teams. I've been hearing a lot about, why there's actually some traffic on the ACHA listserv recently about storing biologics. I mean, even on my highly privileged campus, students don't have good access to mail, and most of the dorm rooms don't have refrigerators. And so if there's, if the idea is that the pharmacy is supposed to send them their medication, or they're supposed to go get it from the pharmacy and keep it in their dorm until they need their next injection, that's not really an option. So, are we able to rewrite our rules? Because our rules would have said, we don't store medicine for patients. There's too much liability in that. But now with, again, emerging up, well, as though it's new, it's been around for, 5-10 years. But with more and more patients needing access to refrigerated, safely stored medications, we might have to rewrite our rules for our own clinic, and as a way to accommodate patients. I mean, we have to inject them or prescribe them, but can we at least help the student store them safely for them to take to their gastroenterologist or wherever they have to go to get the service? So I think that scope of services needs to be a recurring conversation within all of our health services. We need to listen to the customer, voice of the customer, about what aren't we doing. Are we overly proud of something that we are doing that the community doesn't even really appreciate? And that maybe we need to back off on whatever that particular service is and be more willing to provide something else. But it's, again, back to, proving our value. It doesn't serve any of us well when there's a reasonable number of students that simply aren't able to access the services they need because we don't provide them. And if reasonable, informed minds would say that's actually something you probably should be doing in a primary care practice, and especially on a college campus where they're students don't have cars, so they don't have access to the rest of the community, then I think we need to listen, and to the extent that we can, we need to respond. And I'm going to give you one personal example. I'm not sure that this is necessarily a pride point, but it's a very real conversation that we're having right now. So the cost of our student health insurance plan has, exponential isn't even the right word. I don't know. Mathematically,
I think y'all have probably some of the highest across the country that I've seen. So obviously you provide a lot.
You haven't seen the behind the scenes part of that. So so the question is, are there additional services that we could provide at student health that would keep students from needing to access community services, which are just exponentially expensive? Well, one example I would give is IUD insertion. So historically, in our clinic, we've never inserted IUDs because we have such good access to gynecology specialists as part of the university health system. I mean, it's on campus, it's easy access. They like seeing our patients like going there. It's a system that's worked. Well, what if we simply can't afford that for the health plan? I mean, that's not going to solve the overall problem, but $500,000 here and $600,000 there, it starts to add up so if we could bring IUD insertions in-house, for, I'm making up numbers here, but for $100,000 a year and save the health plan, $500,000 a year, that's something that that's a way I can provide value added to the university, because the university is subsidizing so much of the student health insurance costs. And so I also want to take this opportunity to talk about the intersection of the student health insurance plan with cost of running the student health service, because there may be times when I need to become a little bit more expensive on the student health insurance side, and hopefully that would be appreciated and supported by the university, in order to save dramatically on the student health insurance side of the equation. but I can't just take on that cost to save the insurance plan money if I can't get, support for that, that $100,000 service that we're going to provide in-house. So I think it's, in terms of the landscape, the financial landscape of college health, I think the intersection between the student health insurance plan and what's provided on campus is going to become increasingly more important. And it can't be a them versus us. It needs to be how do the entities work together to maximize services for students and try to curb some of the costs to the health insurance plan.
This is interesting because I've been thinking, I was just kind of looking through the people that are on the call, and there's quite a few insurance folks, right? And we work with, insurance as well. And I guess, to go building off of that point, how can the folks that are in the insurance space, I guess, engender themselves more to, your plight, right? And obviously that's that's going to help you, but then it's also going to help them in terms of getting a client like the logo of Stanford.
Okay, so that's data. So depending on whether you're an insured plan or a fully insured plan, and you know this much. Oh, sorry, a self-insured plan or a fully insured plan. In California, private schools cannot be self-insured. So we at Stanford, we're a fully insured plan, but I know there's different models over the country. But I also know that which model you have also determines to some extent how much access you have to the data, the utilization data of the student health insurance plan. But nevertheless, I want the insurer to come back to me with data showing you've spent this much on, I'll just stick with the IUD insertion example for right now. I don't need to know the name of a single patient. All I need to know is, wow, we spent for X number of students, we spent Y number of dollars on IUD insertions by referring out to the community. I want my insurance colleagues to come back and say, we think if you brought that in-house to student health services, it would be a win for your students because they don't have to go pay copays and go out to the community. And we can save the health insurance plan, some amount of money. And I want them to come back to me with 5 or 6 of those examples of ways that with some amount of effort within student health, we can, and hopefully some budget support from the university, we can reduce costs to the health insurance plan and make things more convenient for students. And so my answer to your question is data. And I want you to come back to me and say, we found this opportunity. And compared to other schools, you're spending per capita so much more on IUD insertions or MRIs or orthopedic MRIs than peer schools. What can we do about that? Because it's really, without the granularity of the data, I'm making up things like I just did, like IUD insertions.
Yeah, I think that's fascinating because I think, I hear a lot of brokers, we work with brokers and carriers, and I hear a lot of, folks saying, oh, we really, want to be consultants, right, and provide that consultative care. I think there's very few of them that I've seen. We talked about Mike and Jess earlier. There's there are few of them that go to that step, right? So is that the kind of that consultative nature of it that you're talking about? Because I think right now, especially the carriers brokers are splitting their time between trying to enroll students and waive students and this or that, and then also try to provide care, and it's just you're stretching yourself too thin. So is that kind of what you're referring to?
Absolutely. I absolutely want to be in a consultative relationship with our student health insurance plan carrier. And I want them to bring data because they have the data. So I want them to bring data. I want them to bring some analysis of the data. I'd actually like for them to give me whatever data they're allowed to. so that I can do some of my own analysis. But to your point, I don't want to be constantly talking about the waiver criteria and the renewal for next year. I want the consultation about, how can we um, um, how can we build a better mousetrap? And it's not just a one-sided student health services mousetrap. It's this combination of the health plan and and uh, and the student health service. Now, of course, this also makes a huge difference. What percentage of your student population is insured by the health plan? Because if it's a tiny percentage, then this conversation really doesn't need to happen. But if you have a large, expensive population that are insured by the student health plan, then we absolutely need to be doing this consultative relationship. Um, and likewise, I need to be able to go to them and say, hey, I've been wondering, I noticed that there's been an uptick in the number of students on Humira.
Yeah.
Are there models out there that you've seen, because they've seen a lot more models than we have? Are there models that you've seen at other schools where this has been able to be addressed? That may not be the best example. But I'm just saying that we need to be going back and forth on these conversations.
Yeah. I want to ask one last big question before kind of these, quick hitters to round out the time that we have. But, one of the things that's always been really shocking to me, talking to institutions as from a vendor perspective, is how everything just halts right before and after turnover. There's a ton of turnover in universities right now, right? And leadership continuity is becoming it's a challenge, and I'm sure you've heard it's been an especially brutal summer, from marquee places that I thought were untouchable, like Duke. You mentioned Stanford, Emory. The list goes on, and for me personally, Volta wouldn't exist without Emory, right? I've actually never paid a penny of tuition money there, but Dr. Rabinovitz and her team have been super helpful. So how do you maintain operational stability and momentum during, during this really just crazy time that we live in?
So I'm blessed in that I've had virtually no turnover. Now I did have to, as I said, I had to lay off some colleagues, but the rest of the remaining staff has actually been remarkably stable. And I'm going to credit my directors, my medical director, my counseling director, my administrative director, for creating a culture where people want to stay. They want to continue to be part of what we're doing. I'll also throw in there that a bad day in college health is often better than a good day in that private practice I keep mentioning down the street. And so, how do we both sustain the culture where people want to be here? They want to work with our young adult population, and we're being productive, and we're producing value added for the university. And I think sometimes those are a conflict, but I think one of the responsibilities of leadership is to help to help create that world where we can enjoy what we're doing, and we're being responsible employees to our institutions.
Yeah. No, it's a great question. To kind of wrap it up, just a couple of quick things. What keeps you motivated to do this work? Right? It's not the money. You could be making a lot more money, doing a lot more other. I mean, you have a biomedical, engineering degree for goodness sakes, right? So, what keeps you motivated? Is there a recent moment or like interaction that reminded you of why this matters?
So I'm going to give you a big answer and a little answer. The big answer is I love my job. I get to do every day, I get to do bits and pieces of all the things that I like to do, whether that's academic writing, whether that's seeing patients. And it's critically important to me personally as my own ego structure and my own leadership model. I do still see patients every day. Um, uh, but working on a proposal for something, going to a student affairs meeting, going to a hospital meeting, I get to do a little bit of everything I enjoy doing every day, and I can't imagine a better work environment, a better career. But I'm going to give you one example. Every time I tell it, I get emotional. But this was years ago, so no student that currently I have anything to do with. So this was probably 20 years ago or so. I noticed the next patient on my list was a patient I remembered seeing him a while back, months ago, and it said cold symptoms, which is kind of a very common chief complaint in college health. So I went into the room, started the conversation. I said, "I see that you're here for cold symptoms. How can I help you?" And he said, "Actually, doc, I lied. I actually don't have any symptoms. I just wanted to come talk to you." And it was just such a remarkable moment. So I haven't had moments that dramatic very often since then, but still, again, a bad day in college health is still a really good day. And being able to work with these amazing young adults all over the country that I and everyone on this call gets to work with, in addition to my unbelievable colleagues, both again within my own student health service, but again across the country. Many of the folks, we have common friends in this business. But those are my answers to your simple question.
No, it's a great. I mean, first of all, thank you for sharing. That's deep, right? I think to me, what's really fascinating about this space is that this is the first time that a lot of young people are out on out on their own, right? And it's the first time they're encountering the healthcare system and being able to really mold and shape what the rest of their their lives interactions is going to be with that system is incredible. Last question for me. What do you want to be true 3 years from now?
I'd like for us to be talking less about the national landscape, and that implies less about loss of university funding, loss of student health funding. And I want us to be talking about optimizing our scope of services, optimizing our availability to our student patients. And I don't know if it's 3 years, it might be more like 5, 10, or maybe more. I would love for us to be talking about how much our institutions have come to appreciate. Now, our institutions came to appreciate us a lot during COVID. It's amazing for those 2 or 3 years. And I still meet colleagues on campus who I've never met before, except they knew me from the two-dimensional box on Zooms during COVID, when I was one of the voices of on behalf of the university. How can we gain and sustain that level of importance and credibility for our institutions outside of the crisis of a global pandemic? And I don't have an answer. There very well may be someone on your call that does. I look forward to hearing that when it comes up. But I think we need to be working very hard to establish that credibility, importance, and joy that we had as student health professionals during that very dark time in our history.
It's a great answer. It's a great way to end things. But Jim, thank you so much. We somehow kept most of the people on this entire hour, so that's incredible. But and moreover, thank you for being the first guest. On this series. It means a lot, and I think everybody on here really enjoys your insights, your perspective, and yeah, we're definitely looking forward to hearing more of you and other people on this call. So we really appreciate it.
Dr. Pena, thank you very much for your leadership in this space, for jumping in to establish the current. And I personally will look forward to listening on future versions of this. But just thank you very much for your hospitality and graciousness and allowing me to spend time with you today.